All right, guys. So sorry I was late. It was a busier day in the OR, so I got a little hung up. But thank you for this opportunity to come chat. You might turn on maybe the front. I don't know. Are you able?
Do you need the lights on?
It's up to you guys. It's up to you guys. All right, cool. So today was going to talk to you about this thing that has been kind of emerging more and more. Was traditionally thought about as a thoracic surgeon / vascular surgeon's arena. And since a group in Annecy, France described a way to do this arthroscopically, more and more shoulder and orthopedic surgeons are starting to enter this arena because we can offer patients something that is quite different than sort of the big first rib resections or taking down the pec major and kind of really high comorbid procedures. We started finding solutions for certain patients with thoracic outlet. And one of the cool things has been, I think over the next 10 to 15 years, you guys are going to see a big shift in what we think about the scapula and how we think about it, how it's coordinated with the shoulder. And I think this is on the realm of what exactly is going on. So I'm sure you guys have seen patients with scapular dyskinesia, or when they kind of bring up their arm, their scapula kind of pops back, or their scapula is not moving like you think it should. I'm sure you also have seen patients, maybe because they work out a lot, maybe because they have poor posture, that sort of are kind of hunched over, their shoulders are kind of protracted forward. Have sort of kind of vague pain from it. These are kind of all things, at least in my mind and in a lot of our minds, on a spectrum of this sort of quote-unquote thoracic outlet, scapular dyskinesia kind of problem. And I'm going to kind of share with you at least how I think about it, how we are studying this, how we're trying to learn more about it, and the success we've had in some early preliminary results. We actually just submitted a multi-center study on this. Myself, a group in Switzerland, a group at the Mayo Clinic in Rochester, and showing some pretty promising results in very early, kind of very short-term patients. So, neurogenic thoracic outlet and other sort of plexus type symptoms, kind of rethinking how you diagnose and how you treat them. Don't have anything disclosure relevant to this. I do think this is one of the more interesting topics to talk about because it's something that most people, especially orthopedic surgeons or their kind of associates, don't really think a lot about. So nobody's here without mentors, and these mentors are some of the ones that I was telling you about, both here and abroad. The one on the right is the one who first described this idea of arthroscopically releasing the pectoralis minor and thus enabling orthopedic surgeons to play a potentially more prominent role in this thoracic outlet idea. And then some of these guys are some of the ones that we just did that multi-center study with. So here's a case, real life case, and I'll show you. She gave me permission to show you guys. So I will show you a little bit, but this is a 22-year-old softball player. Has had ongoing pain for a while. It's gotten worse. She's had some paresthesias. She's had a C-spine workup. She's been diagnosed with a slap tear. She was sent to me when she was, one of our sports surgeons was going to do a slap repair on her, but didn't really think that her symptoms matched what typically happens in the slap tear. And then has had kind of weakness and has really gotten to the point where she can't play softball and is in her junior year and was thinking about basically quitting and kind of moving on. As you think about that patient, we're going to go into some sort of stuff. I'm going to revisit this patient at the end. I'm going to kind of show you what we did and how we treated her, and then how we kind of think about stuff. So before I start talking about all the thoracic outlet stuff, I want to kind of give us a little bit of a forward about if this brachial plexus idea or this patient with a pain that radiates anywhere, radiates down their shoulder, radiates down their arm, radiates to their hand. There's a whole bunch of differentials on that, and obviously cervical radiculopathy is probably the top of anything that you look up. Compressive neuropathy as well, but cervical radiculopathy is really on the top of everything. And as you know, these nerve roots can get compressed. They can be quite painful. They have a variety of different areas that can be compressed, and they have a variety of different symptoms. And I'm definitely not here to tell you how to diagnose that, because that is not my interest, nor is it my specialty. Nonetheless, just literally having patients move their neck really gives you a lot of sense into this. I'm also pretty quick to refer because of how difficult it is to treat late on in the game. Then you have this idea of this brachial plexus and these brachial plexus syndromes. So the brachial plexus, as you know, comes from your neck. There's C5, C6, C7, C8, T1. Goes down through the scalenes, underneath the clavicle, underneath the pectoralis minor, which inserts onto the coracoid, and then travels sort of in the medial aspect of your arm, and then kind of branches out into these cords and roots. And as you know, the plexus controls just about everything that moves your extremity. Trapezius is one of the few things it doesn't control, but almost everything else it controls. Most of the plexus stuff we're talking about are either traumatic, like stingers, or high energy mechanisms that leave patients with significant disabilities. We unfortunately here in Atlanta, especially given I am one of 7 hand surgeons that take call at Grady, do see a lot of penetrating trauma that's associated with plexus. And if I can be frank, it's crazy, probably one of the few cities in the country you see more of that than you see of the car accidents with it. You see a lot of, unfortunately, penetrating trauma, and that's, it seems like a lot of the plexus that we've been doing has been because of that instead of car accidents, which everywhere else in the country is because of car accidents or snowmobile accidents or whatever you want to call it. So upper trunk is the most common. It's the traction injury. It pulls out C5 and C6. It's mostly your shoulder that's weak. It's mostly certain motion in your shoulder. Sometimes your elbow is affected. Lower trunk is less common. It's usually if somebody kind of catching themselves up above and kind of avulsing the lower aspects of the nerve roots. It's well, they're both difficult to treat, but this is very difficult to treat because it's really like an ulnar lesion. Just like you have a really bad C8T1 radiculopathy, these are difficult, and these don't recover very well, and patients don't do tremendously well. Obviously, there's a lot of evaluation that you can do, and then there's these like I bring up trapezius because trapezius is not innervated by the brachial plexus, so that is always an option to help to treat this. But there's not a lot of options in these patients. That's a whole sort of another topic. Obviously, when you're rehabbing brachial plexus patients, regardless of what they had, whether they had a surgical management or not, if you pay attention to their scapula, it's interesting. The plexus patients that I've seen that have regained function, meaning they've regained muscle strength, but actually have not regained function, when they get the plexus injury, their scapula is destabilized. The serratus is innervated by your brachial plexus. So are the rhomboids. So are the rhomboids, and then so are a lot of the things coming off of it. And so it definitely it takes some time to retrain the scapula, in addition to everyone wants to focus on the deltoid. And are they getting some deltoid function back? And great, they're getting deltoid function back. But nobody focuses on the fact that the serratus is innervated with the same nerve root as the deltoid. And so if the deltoid's out, the serratus is probably out, and vice versa. And so it's real important to sort of focus on the scapula and rehabbing these patients. And that is something that I think is sort of missed a lot. Biofeedback is one of the many techniques you can obviously use to this. We published on this and after various tendon transfers. Axillary nerve is usually the one you're more commonly focused on with plexus. And if you think about axillary nerve, always think about this idea of quadrilateral space syndrome. It's not that common unless you're talking about muscular people and athletes. And when you start talking about that, it actually is more common than you think it is. It's people that get their axillary nerve pinched as it's coming around, coming out of the quadrilateral space, coming around the humeral shaft. There's some pretty classic findings like MRIs that demonstrate, teres minor atrophy or pretty specific locations of pain in the posterior aspect. But really advanced quadrilateral space, I just saw a patient a couple weeks ago that had deltoid atrophy from it. Like legitimately The rest of the posterior cord was fine. And the way you can diagnose quadrilateral space versus a deltoid injury is that the quadrilateral space, the main thing it affects is the middle and anterior trunk, while the posterior deltoid and the teres minor are going to be basically spared until very, very late. So if you have isolated anterior middle deltoid paralysis, I mean, if I can be frank, if they haven't had surgery, it's probably quadrilateral space syndrome. In general, Parsonage-Turner is another one to keep in mind. I had a patient who one of my spine colleagues had been treating for a while with this presumed radiculopathy that's causing upper extremity weakness, and finally sent to me saying, like, I just doesn't, we decompress him, this and that, it's not getting better, we're not exactly sure. If you listen to the patient's story, the pain started, and the patient had basically a flu-like symptoms. 4 days later, the patient had severe shoulder pain, like they'd been run over by a car. Severe shoulder pain, and then they couldn't move their shoulder. That is like as classic as it comes for Parsonage-Turner. And the beauty is it usually goes away. The problem was they'd been working up his neck the whole time, assuming all this was from his neck and his cervical radiculopathy. And so unfortunately he is recovering. He has recovered a lot of his function, but it's something. If you hear that, severe pain without a trauma followed by weakness, that's Parsonage-Turner. I mean, it's plain and simply that's what it is. I did my training up at the Mayo Clinic, and we had a lot of people referred all over the country with Parsonage-Turner. They flew across the country for a brachial plexus thing. They had no history of trauma. They had no history of like any actual injury. And they had this story of severe pain followed by weakness. And usually there's some sort of URI, if you really tease it out, built in there at some point. All right, so that's kind of the introductory part of this. This is when I want to get to the more fun stuff, the more meat stuff. So thoracic outlet syndrome. And what is thoracic outlet syndrome? What are we talking about? And then why is an orthopedic surgeon up here talking to you about treating it? All right, so the brachial plexus. You can see the brachial plexus is coming underneath the pectoralis minor. So you have it goes through the scalene, under the clavicle, under the pectoralis minor, right next to the axillary artery, right next to the axillary vein. The rib cage right here. And so you can see that as this, it's literally, besides the serratus really is what controls the scapula, but it's the anterior connection to the body of the scapula. But you can also imagine if the scapula is not working so well, you can imagine this muscle is going to compress on what's underneath it. It's not too far-fetched if you think about the anatomy to think why the pectoralis minor, which we don't exactly know why we have it to begin with, because we do know when you take it down for a ladder J or for a variety of other stuff, patients do fine. They have no real dysfunction. So we've known for 40 years that pectoralis minor does nothing for shoulder that we know of. But nonetheless, the pectoralis minor does overlie all of these very important structures. Y'all can imagine if something's going wrong with your scapula, why patients would have pain on the front part of their shoulder, because all those important structures are being compressed. There's vascular and there's neurogenic. I'm going to briefly introduce vascular to you and this idea of vascular thoracic outlet. So vascular thoracic outlet is the hard one. That is the one where usually either an accessory rib or a very high first rib or something is going on with their anatomy, and this rib and this clavicle are pinching together, and it's not a neurogenic problem. It's not a scapular problem. It is an anatomic variant that has caused them to have this very serious problem. Usually it's in women. Usually people are diagnosed with Raynaud's syndrome or Raynaud's phenomenon. Not that everybody who's diagnosed with Raynaud's, because that's relatively common, has it, but nonetheless they usually have something like that. And usually their symptoms are in the hand. That being said, it is not that common. If you look at all thoracic outlets, not common to begin with, and if you look at all thoracic outlets that are out there, vascular is like 3% of all thoracic outlets. So vascular is not common. It is an anatomic variant that they were born with that eventually over time they developed. It's really rare. It does happen, but it's really rare. And we used to think it was a lot more common than it actually is. There's a variety of tests that we're going to sort of talk about and show you. And it's real, in my mind, pretty easy to distinguish vascular versus thoracic just based off of these tests. Now, these tests, other people who don't have thoracic outlet, also these tests might be positive. They have shoulder pain or even some neck pain. But so adds and tests, you can kind of see the example. You are going to extend, or you're basically going to try to compress this clavicle and this pectoralis minor against the rib cage. And you're going to ask them to inhale deeply with the idea of inhaling this and stretching that back. The idea is you're trying to compress the vessels. You're trying to trap the clavicle underneath into the first rib. You're trying to this. Adds and tests for vascular thoracic outlet is reduced pulses. You're putting your hand on the radial pulse, and it goes away when you do this. It's pretty striking when it goes away. Like legitimately, you do this, you breathe in, and all of a sudden, they have no pulse in their hand. And you had a strong pulse, and they have no pulse in their hand. So it's not a subtle, oh, I think maybe it's gone away. Not. It's their pulse completely is gone. When I say vascular thoracic outlet is very striking, it is very striking when somebody has it. It is not a subtle diagnosis. So neurogenic thoracic outlet, traditionally, when we first learned about it, there's 2 sites of compression, and the way they thought about it was you'd have to sort of dissect out both sites. You'd have to dissect out this idea the scalenes got compressed, and you'd have to dissect out the fact that the pectoralis minor and the clavicle were compressed. And so traditionally, the way we would treat this was we would go in, we would resect out the scalenes in the neck, we would release the pectoralis minor by taking off the pectoralis major or splitting, having a big incision in this pectoralis major, take off the pectoralis minor, and then most of the time either taking off the subclavius and either osteotomizing or decompressing the clavicle, or taking out the first rib. And if I can be frank, a lot of times it was taking out the first rib. One of the shocking things to me, before I realized some of the more minimum invasive options, was during my shoulder fellowship when a thoracic and brachial plexus specialist hand surgeon at Massachusetts General killed an 18-year-old girl in the OR doing that procedure. Like, legitimately, she died in the OR 2 hours down from me doing this procedure. Taking down this pectoralis minor, taking out the first rib. It is a very, very significant procedure. It is taking out the first rib is not benign. Taking down, you're bound some very important vessels, you're mobilizing some very important vessels, and it is a very serious problem. This is why thoracic outlet has the idea of this very difficult, very feared diagnosis, because it's serious complications. These are not the patient has a recurrent rotator cuff tear, or the patient has continued subtle thenar pain after a couple of them. These are very serious complications that I had. This is why thoracic outlet in general, most people say thoracic outlet and you're like, no, thank you, like this, no, stay away from this, is miserable. And if you look at the literature, it supports this. So very serious complications with these. And even when they went well, patients didn't love them. Nonetheless, we are learning that neurogenic, you don't necessarily need to do the first rib. And the first ribs really, in 2020, should be reserved for the vascular. It's not always, and people are we're still kind of evolving on this. And it kind of depends on who's treating, because a thoracic surgeon is going to be much more aggressive at taking out the first rib. But I don't know if you guys ever have known any patients who've had first rib resections, but I haven't met a lot of them. And I have yet to meet one that is very happy with the outcome of their surgery. So physical exam-wise with thoracic outlet, I think for me, the compilation of symptoms are you have some sort of scapular dyskinesia. It's not necessarily true scapular winging, but it's more something's going on in the scapula. It's sort of dyskinetic or not really working right. the Tenelles at the Tenelles right next to the coracoid, so everybody can feel their coracoid. You know, your coracoid's right off of your clavicle. Everybody can kind of feel their coracoid. Your coracoid shouldn't be so painful to palpate. If you push medial to your coracoid, it shouldn't be too painful. I mean, it's a little sore, but it shouldn't really be too painful to palpate. If it's painful, it's probably not good. And if you tap right there, right next to that coracoid, and you tap right there, and all of a sudden you have shooting pain going down your arm, that shouldn't happen. These are buried by your pectoralis major, by your pectoralis minor, by a lot of tissue. It should not cause shooting down your arm. I mean, it's not even subcutaneous like your cubital tunnel or your carpal tunnel. These are very subcutaneous nerves, and yet it doesn't always cause shooting, right? This should not cause shooting unless it's really inflamed. It's cause shooting down the arm that is pretty specific. And then this idea of the suprascapular stretch test I'll show you, but the suprascapular test is basically where you kind of bring the shoulder back in one way and you kind of bring the head back in the other. The idea of kind of compress the it's like the Addison test, but it's really kind of more focused on the scapula than it is on the hand. And then the Addison test. So the Addison test for vascular is and this is incorrect. So this should be numbness and tingling, not reduced pulse. So the Addison test for vascular thoracic outlet is reduced pulse. The Addison test for neurogenic thoracic outlet is numbness and tingling. You take their arm, you bring it back like this, you stretch them, you hold it there for about a minute, and they get numbness and tingling. It's pretty predictable. I mean, they say that these tests aren't perfect, and they're not. And probably people have positive findings in these tests that don't actually have this. But I should be able to sit there and hold my hand here for a while. I should not get numbness and tingling. And then the Roos test is this is my favorite test. Addison test I like. Inhale deeply. I think it makes sense. But the Roos test is really my favorite one. So because it's really, if you think about your scapula and the pec minor, it's really bringing this back, stretching it, that pec minor against your brachial plexus going underneath it. This is also the thing that people have that we should really work on getting their posture back, getting this stretched out, getting them to do this without pain. This is what you have to kind of focus on when you're trying to get these people better is that. So this motion really shouldn't cause pain. But it really does. This is pump hand 3 times. I don't actually have them do that. I literally just hold them and I talk to them. I hold them and I talk to them about other stuff, but I'm holding their arm like this. And then pretty soon, if they have it, they will within a minute, probably within 30 seconds, they'll be like, can we stop? My hand's numb. Can we stop? This really hurts. Something like that. And sometimes when you do it initially, it'll be painful. The right test is very non-specific, as you can imagine. Anybody who has shoulder pain is going to hurt when you really stretch them up like this. So it's not necessarily the most helpful, but it's kind of like this Roos test. It's the right test was designed to be a blend of the two. What I do like about the right test is it kind of helps you to see when you have them do this. If they have pain in their like in their neck versus in their chest, it does kind of help to differentiate that, because you can get compression at your scalenes. It's not so common. I think we used to think it was way more common than it is, but I have seen a couple of patients who you do this and they're like, "Ow, my neck really hurts," and that's potentially telling you that there's more than just down the pec. So there's high false positive in these tests. Meaning that just because people are positive when you do this, when you do this, when you do this, and you think about all these tests, they're all names, don't remember the names, who cares about the names? Think about it like this: when you go down, when you go up, when you go up. That's really what we're doing. And if you think about it, inhaling deeply is just making that space smaller and smaller, right? It's the same idea of flexing your elbow for your cubital tunnel, same idea as doing this for your carpal tunnel. It's making that space smaller and smaller than inhaling deeply is. If you think about neurogenic thoracic outlet and suprascapular neuropathy, which is one of the things that we're going to kind of talk as a corollary of this, they're actually very similar to concepts of carpal tunnel and cubital tunnel. So if you kind of understand those, it's kind of the same ideas. You're kind of doing the same things that you're doing when you're diagnosing and in essence, in some respects, treating. I do want to point out real quick though scapular winging, so dyskinesia and winging are different. And dyskinesia is when you have them go up and down. Their scapula moves, but it's sort of dyskinetic, especially when they come down, especially if they come down slow, it kind of pops a little bit, or it just doesn't, when you look at both of them, they don't move the same. Winging, so true scapular winging is different. That means that there's a muscle that's not working. Trapezius serratus. This young woman has a serratus anterior palsy. That scapula is not working. So you can see with the serratus anterior palsy that her scapula is popping out. Or trapezius. Trapezius means that trapezius is not working. It's not a subtle thing. It's not a dyskinetic thing. Her scapula does not move. It does not externally rotate. It pops out. It does not stay against the body. And when I hold it against the body, she's able to elevate her arm. See in a second. See, she elevates her arm. She could not move her arm. I hold her scapula against her arm, and she can elevate her arm. It's because the serratus was not holding it against the body. The trapezius. This gentleman has had trapezius palsy for almost entire life. He has done a phenomenal job of compensating. He has his rhomboids that have compensated in his levator scapula. It's incredible. One of the more compensated people I've ever seen with trapezius paralysis. That being said, he cannot externally rotate his scapula. His scapula stays here. When he tries to raise it up like this, he can't externally rotate it because that's the main function of trapezius is external rotation of the scapula. So it does not rotate around when he raises it. Thus, he has these dysfunctions. These are not scapular dyskinesia. These are different problems, different treatments, different thoughts, different everything. Scapular dyskinesia is much more subtle. And these are some of the ways that you treat these pec major transfer, triple transfer. So how do you work up neurogenic thoracic outlet? This is still evolving, and we are in the process of helping to contribute to this. The brachial plexus MRI has been this really cool technology that's evolved over the last 5 to 10 years where we can actually visualize some of these nerves pretty well on MRI. Obviously EMG, you want to make sure it's not a C-spine thing that you're dealing with. You want to make sure it's not a peripheral neuropathy thing that you're dealing with. You want to make sure, most of the time in neurogenic thoracic outlet, EMG is negative. If it's stone cold negative, that actually is more reassuring than if it has some other finding on it that's potentially clouding the picture. The other finding you can have is that your suprascapular nerve is affected by it. And I have seen some of these patients, including the one I'll show you in a second. Your suprascapular nerve, so the one going through your suprascapular notch into your supraspinatus and your infraspinatus, that nerve is, I think, one of the first ones that really gets affected by it because it's like I said, it's all on the spectrum. It's scapula. When your scapula's not moving right, that nerve gets compressed. And we'll talk about suprascapular neuropathy in a second. For me, how do I diagnose this? I think about how they are on physical exam. I kind of like really tenderness, the tapping, the kind of image, but really how I diagnose this and how I really think about it. And when I'm actually serious about either like really focusing on a focused physical therapy or even surgically treating these patients is when this is positive. So diagnostic injections into the suprascapular notch and the pectoralis minor. You should not inject your brachial plexus and it should feel better. If you inject your brachial plexus on your pec minor and the patient's like, my shoulder like is unlocked, my shoulder feels amazing, my arm feels amazing, my hand feels amazing, that should not happen. You're numbing up the nerves that go to your hand. If that happens, that is pretty specific, at least in my mind, that's pretty specific. That is not part of anything you'll read in the literature. That is something that I think we are learning about and evolving. I have an ultrasonographer who does this. He works in a clinic right next to me. We do a staged injections, or he does this one about 2 to 3 weeks before he does this one. And this one, he does it when I'm in clinic right next to him, and he schedules the patient about an hour before the patient sees me, and he does lidocaine only, and he sends them to my clinic, and I look on the patient, and I push on them, and I do all these different maneuvers on them. And I compare how it was when I first met them versus how it is now. It is striking when that's positive. It is striking when that works. It is not a subtle, maybe I'm feeling better. It is literally, I wish I had taped her 2 days ago. I had a patient that was striking positive, and she literally was like, look, my shoulder feels unlocked. I can bring my shoulder back. I can restore my posture. I can move my shoulder again. Like legitimately, my shoulder feels normal again. From a lidocaine injection into the brachial plexus. And all of a sudden her shoulder feels normal again. That just should not happen unless there's something going on underneath that pectoralis minor, unless those nerves are not happy. Same idea as when we inject carpal tunnel syndrome and we say the reason why we do it is because it predicts surgical outcomes. In my mind, that's really one of the mainstays for injecting carpal tunnel syndrome is we haven't really shown that we can treat it with injections. It's very mixed on the literature, but we have shown people who respond to injections do better with surgery than people who don't respond with injections. There's been 3 randomized controlled trials that have shown that. So it's pretty clear in the literature that that is a thing. I think that's the same thing here too. So once again, this is my diagnostic criteria. If anything, if you remember anything from this talk, this is in my mind, this is rethinking thoracic outlet syndrome. So Tinel's or tendinous palpation near the pectoralis minor, positive stretch test, scapular dyskinesia, positive response to guided injections, negative vascular EMG workup. And when I say vascular workup, we don't exactly know what that means. What we do, and I don't know if this is right, we're hoping to try to figure this out, but what we do to see if there is any critical vascular compression is we do an MRA or an angiogram with patients like this and patients like this. Our idea is you're like this and all of a sudden the axillary artery is completely shut off, probably that's a vascular problem. I don't know if that's right. There's not a lot of literature on how to actually diagnose these outside of physical exam. It makes sense to me. This is why we've sort of instituted this. I'm working with one of our radiologists to try to better improve this and maybe better understand exactly what we need to do in addition to, I'm pretty convinced about the guided injections. The other stuff I'm not quite as convinced about. So how do you initially treat this? Well, just like you're treating anything, anybody that has any type of scapular dyskinesia, scapular problems, something, focus on the scapula, focus on stretching, focus on posture. Whether it's sternoclavicular joint, AC joint, neurogenic thoracic outlet, scapular dyskinesia, scapular thoracic bursitis, whatever you want to talk about, focus on the posture. And that's not just when they're working in therapy, that's not just when they're in your office. This is tell them they have to act like a book is on top of their head. They have to focus on bringing their arms back. I have a gentleman who has a SC instability, who we are probably going to end up, sternoclavicular instability, probably going to end up operating on him. But we have, literally he's gone from like, he showed up my clinic like this, and he literally the other day was like this. And he's like, now, he was begging me for surgery when he first showed up. And now he's like, I don't know if I really want it anymore. And it was just by correcting his posture, his sternoclavicular joint was less symptomatic. But when he was like this, and when he was walking around like this, he was grinding into that SC joint. And now he's like this, it doesn't bother him as much. It still bothers him when he really lifts heavy things, but for the most part, it's not really bothering him that much. He's not sure if he really wants to undergo the reconstruction. So posture is huge. Posture is something that's not just, you know, your etiquette class telling you need good posture, or I like to dance. It's not this like, you know, dancing, you need good posture. It is something that we all, in our generation of computers and screens and stuff like that, we all like probably struggle with. I think from what I've seen, guys struggle with it more than girls, but nonetheless, everybody struggles with it, and I do think it's a really important thing to kind of hammer home with. And then focusing on the scapula. I do think TLSOs actually have a role in this. I don't know exactly what role it is, but we have been giving people various types of TLSOs. The same thing that our spine colleagues do, and I do think there potentially is a role for some of these patients that have some scapular problems and actually getting them to focus on bringing their shoulder back and kind of holding it back in place. I've had some nice success with these. All right, so surgical management. So this is the other aspect of rethinking neurogenic thoracic outlet. So here is the original article. So my friend Thibault Lafosse, he did his PhD basically describing the anatomy / like how to actually do this technique and whatnot. And then Laurent Lafosse was his father, also one of the best shoulder arthroscopists in the world. Still is, but has really revolutionized a lot of stuff that we think. Subscapularis tears, the Lafosse criteria, or the Lafosse grading system. So I mean, these are sort of giants in shoulder. But so Thibault described this as this technique. So you arthroscopically release the pectoralis minor and release the suprascapular nerve, and potentially treat this idea of neurogenic thoracic outlet without actually making a big incision and potentially doing it much safer. We just submitted this to the Journal Shoulder and Elbow. We just got this accepted to the Journal Shoulder and Elbow. We are in the process of going through revisions. Myself, David Hani is in Basel, Switzerland, Awasim El-San, Joaquin Sanchez at the Mayo Clinic in Rochester. We looked at our short-term outcomes, so our average follow-up is a little over 2 years in 42 patients with this idea. So short-term, but patients did well, and there was zero complications. So unlike this first rib resection thing, knock on wood, there was 0 complications. And for the vast majority of the patients, they did well. Not every patient, but a lot of them, a lot of 42 did quite well. Oops. Are we back on? Perfect. All right. Before I go into the sort of case series again, I just want to spend a moment talking about the suprascapular nerve. So I do think that this is all on a spectrum. I do think it's all on a wave. I do think scapular dyskinesia, suprascapular neuropathy, and neurogenic thoracic are all kind of like this one spectrum. So the suprascapular nerve, and this can be compressed in rotator cuff problems, especially the partial thickness rotator cuff variety. But this can also be compressed if you have your scapula not moving. And it kind of makes sense. If your scapula is not moving right, you see a ligament coming in a tiny space underneath, a nerve coming in a tiny space underneath a ligament. Kind of makes sense. If your scapula is not moving right, that nerve is probably not going to be too happy, right? Same idea with your carpal tunnel. So the places that you have a nerve underneath a ligament, where are those places? Your carpal tunnel, your cubital tunnel. Both of those places, something happens, the nerve's irritated, something's not moving right, or there's inflammation, they have pain. So why wouldn't the suprascapular nerve also have pain? It's one of the few areas in the body where there's a nerve traveling underneath a ligament I guess tarsal tunnel is the other one, but that you can potentially have pain. So it makes sense. Everybody, traditionally, when I was in residency, we all talked about, this cyst that was compressing the suprascapular nerve, and we needed to go in and debride that cyst. But I think the attention has really shifted to the actual suprascapular nerve. In my mind, the patient that has it, not necessarily with neurogenic thoracic outlet, but in my mind, the patient that has it, we don't have a perfect physical exam finding for it, but the patient that has it is the one that has the kind of medial shoulder pain that kind of radiates to their back, because as you can see, the suprascapular nerve comes in and travels down to the back. It innervates the upper 50% of your glenohumeral joint. And so it's just like the neurectomies that you can do this denervation procedure for your wrist arthritis. It does innervate the glenohumeral joint. But this suprascapular nerve, I do think it is important to think about with patients who have shoulder pain. And I do send for a lot of diagnostic injections. In my mind, the only way to diagnose this is through an injection. So an ultrasound-guided injection, where I don't do ultrasound, I'm not very good at it. But my ultrasonographer, I've seen where they can visualize this notch, get the needle right in that notch, inject a bunch of lidocaine and steroids, and patients do feel markedly better. One patient in particular, I did send a referral. She ended up going to my CRPS clinic because I thought she had CRPS. Severe pain, barely brushing her shoulder. The severe pain, we inject her suprascapular notch, and we have yet to do surgery on her. She's feeling great. It has yet to come back. So I do think it's something to consider. It's not every patient is like that. I've had plenty of patients I send for injections, and they come back and they're like, "This is like I'm no better," or it's even worse if they tell you they're worse after that injection. But anyway, so suprascapular nerve comes from the upper trunk, comes from C5 to C6, and you can see it branches off of the upper trunk. And it innervates the supraspinatus and it innervates the infraspinatus muscle. This is the suprascapular notch. This is the spinal glenoid notch. Deep shoulder pain, weakness of supraspinatus and infraspinatus is kind of a late finding, but it can happen, especially infraspinatus. It can happen. This is the stretch test that we're doing. So this is what was initially described. So it's kind of like one of the thoracic outlets in them, but then you're also arcing your neck, and they have some pain when you kind of bring their shoulder blade back. Really though, it's the history. It's the medial shoulder pain that kind of radiates to the posterior. That's when I would send somebody for a guided injection. And I do this on a lot of patients that I do rotator cuff repairs on, because that's actually the initial thing it was prescribed for, is in the setting of rotator cuff pathology. If the patient just tells me they have shoulder pain that's pretty mechanical, I don't. But if they tell me they have this medial shoulder pain, this radiating shoulder pain, or it's like kind of posterior shoulder pain, I'll send them for injection because in my mind, there's not a lot of harm to sending for them for the injection, and if they get better, there's pretty good science that says you should release their nerve. I know it's not a common thing among shoulder surgeons, especially sports surgeons, but it's something that I think is going to become more and more common as we see more and more patients after our biceps and distal clavicle and et cetera, not working. I think more and more people are going to start looking at this as a possibility. So diagnostic injections, I kind of talked to you about the diagnostic injection, and then EMG plus or minus. I don't get EMG as in everybody. Spinal glenoid notch cyst, so that's different. So this is where you have a labral tear and it causes a cyst, and usually this presents with some sort of external rotation weakness. That's very, very different. That's usually a young athlete, and then you probably do need to decompress that, but that's not very common. It's quite rare. The suprascapular notch is different. It has a ligament. It affects both the supra and infra, and I think it's more common than the spinal glenoid notch, but that has yet to be sort of determined. Obviously, once again, stretching, scapular strengthening, kind of the same thing that we're talking about with the suprascapular nerve. And once again, really focusing on your scapula. All right, so let's talk a little bit about how you release this. So this is some artistic diagrams, but you can do a arthroscopic release. In the brachial plexus world, they do an open release of this nerve when they do the suprascapular nerve transfer. In our world, we release it arthroscopically. So you basically just follow the way I do it is I follow the CA ligament to the coracoid. I follow the coracoid back to the CC ligaments, and the CC ligament is right next to the transverse scapular ligament. The other way you can do it is just kind of follow the anterior edge of the supraspinatus. I'll show you these in a second. So here's the ligament. Here's the ligament. Here's the cut ligament. So ligament, nerve, ligament, nerve, in the process of cutting the ligament, ligament, nerve. See all the inflammation around there? I've yet to see somebody who got a response from an injection who did not have a bunch of inflammation around that nerve. Like you look at it and you're like, holy mackerel, how is this nerve? Like, why do we have this ligament? This makes no sense. The nerve already, you see a lot of inflammation back here anyways. The nerve is like, there's not a lot of room for that nerve. That nerve is a relatively big nerve. It's not a lot of space for this nerve. And almost always it floats up right in the middle. I can cut the ligament and it floats right up. It's pretty satisfying, I have to say. The more I see and the more I show people, I feel like the more you believe it's real, because when you do this, you're like, holy mackerel, this makes sense why this would be compressed. Look at this, all this information. Carpal tunnel syndrome, you're like, oh yeah, this is a thick ligament. This is probably compressed. But the median nerve doesn't float up when you release the carpal tunnel. In this, you're legitimately, it pops up through the ligament. So, all right, final thought. So this is the cool part of this presentation. So, going back to our lady, I'm giving a little bit more details than what I did initially. So, collegiate softball player. She has had pain radiating down her arm for about a year. Her shoulder subjective value, it's a really nice question that is becoming the standard of care with regards to patient-reported outcome measures for the shoulder. So it's 0 to 100, what do you rate your shoulder? So simple, so easy, has now been shown to be better than the ASES score, the constant score, or the thing for rotator cuff, for shoulder arthritis, and for recurrent shoulder instability. Simple question, one question versus 20, but it's such a powerful question. 0 to 100, rate your shoulder. 0 to 100, rate your thumb. 0 to 100, rate your elbow. That is the best way, in my opinion, to track how a patient's getting better or worse in their mind. All these other patient-reported outcome measures that we fill out, I think this is the simplest thing. 0 to 100, how do you rate your shoulder? How do you rate your shoulder compared to normal? Physical exam, active, not obese, positive suprascapular stretch test, positive in everything that I talked to you about. Just moving your arm in this way was positive. Tenderness of palpation at the medial, at the pec minor, and had some weakness, but it wasn't like true weakness. It wasn't like a true muscle actually being weak, because I think it was more inhibited by pain. All right, so here she is. So you saw an example earlier, but all right, you're tapping at the scalenes, then tap right next to the thing. I'm not even tapping that hard. I'm tapping right next to her. She has pain radiating down her, from doing this. She has positive suprascapular notch stretch test. She has a positive Addison right test. And then, I don't know if it shows so well. For me, if you have somebody really muscular, you can sometimes see these really nicely. But you can, I don't know if you get in the sense, I'm trying to show you how when her scapula rotates back, instead of just coming back smoothly, it goes like this, and it kind of pops a couple times, and it kind of just, it doesn't have that smooth external rotation, internal rotation like our other side does. So she was sent to me for this, not sent to me for this, sent to me by my sports colleague because he was going to go and do a slap repair on her. She's an overhead throwing athlete, she has shoulder pain, she must have a slap tear. If you can't get my sarcasm, I think we do way too many slap repairs in this country for people who probably don't need to have slap repairs done. Nonetheless, that was why she was sent to me. But you look at this, relatively benign. I mean, good-looking cuff, good-looking joint, good-looking muscle bellies. Her EMG, don't have to go into too much detail about this, but basically the only finding on her EMG was that actually, interesting enough, she did have 1+, so not much, but did have some changes in her infraspinatus and her supraspinatus. We've had a couple of those with this whole neurogenic thoracic outlet idea, having this. This is definitely more the exception than the actual norm. But this is partly why I was showing you this, because it gives a nice example of kind of both. CT angiogram, this TOS protocol is negative. We've gone away from CT angiogram. We're doing MRI angiogram now. One, you can kind of tie it in the brachial plexus MRI. Two, I think it's less radiation for patients. But nonetheless, angiogram was negative. And diagnostic injection into her suprascapular notch gave her 80% pain relief. The pectoralis minor diagnostic injection, at least according to her, gave her 75% pain relief and functional improvement. Thus, in my mind, we made the diagnosis of neurogenic thoracic outlet with suprascapular neuropathy. In my mind, she was the example of the spectrum. She had scapular dyskinesia that probably started. Eventually, I think her suprascapular nerve probably got irritated, and eventually she got some weakness from it. Not true weakness, but it was starting to get some true weakness from it. And then eventually, I think she got neurogenic thoracic outlet. I think it's a spectrum. We are trying to describe the spectrum right now, but I really think it's a spectrum. She had been doing, fortunately had been seen by a variety of very, very good therapists who had been doing a lot of really good scapular strengthening, scupulohumeral retraining. We tried to add in a TLSO, did not work for her. She did not have any Botox injections. I don't believe in Botox injections. I've yet to see those work in anything outside of like Raynaud's, really severe Raynaud's phenomenon. But nonetheless, she did not have that. But it's partly because I'm not such a believer in that. And so we tried some. When I met her, we tried even more, even though she'd already had a bunch. So ultimately, we decided to do the surgery. So this is a suprascapular nerve exposure. So this is the backside of the coracoid. I've exposed the suprascapular nerve. That is the CC ligaments. This is the CC ligament that you get when you get AC dislocation. These are what pops. This is the nerve. So you can see that this is the CC ligament going up here. Here's the transverse ligament going here. The nerve is underneath that transverse ligament. So you can see that I'm clearing off the nerve arthroscopically. You can see you clear off the nerve. I use these arthroscopic scissors. They look big in this. They're tiny. Remember, everything's magnified 1,000,000 times in this. They're these tiny scissors, and then there you go. You can see her nerve. So you release the ligament. The nerve almost always sort of pops up. I often will trace it back a little bit just to see if there's anything. But once again, you can see ligament, CC ligaments going up this way. There you go, CC ligaments going up this way, the ones that are important for your distal clavicle stability. I'm following the coracoid, so this is the coracoid. I'm going along the coracoid, So coracoid, you remember, attaches to your short head, your biceps, and your pec minor. So I'm going along the coracoid. There's your CA ligament above you, and then I've just flipped to the outside, and now you can see. So coracoid, hold on one second. So coracoid, your CA ligament going to your acromion, your coracoid, your short head, your biceps coming up to your coracoid up here, and your pectoralis minor over here. So now I'm exposing the pectoralis minor. So here's your pectoralis minor going up. This is your short head, your biceps, and then the brachial plexus underneath it. So now staying on bone, releasing raphe bone, so all the important structures over here. Here's your pectoralis minor. You can see I'm releasing it off the coracoid. So I'm staying on bone once again and releasing it just like you would with Flyer J, but this time doing it arthroscopically. Releasing it right off bone. There's fortunately, when you're staying on bone, there's not a lot of danger there. I am showing you though, that is a brachial plexus, that is actually already that's beating. So you can imagine if you're doing this open, you can't see, this is dangerous. Arthroscopically, you can see everything. I don't think it's near as dangerous. I don't think you're near the problem. So this kind of gives you the idea. So there's the pectoralis minor. You can see I can't even bring it back. So it's retracted back. That's the brachial plexus underneath it. Pectoralis minor has been released off and it pops back. Almost always that I've seen it really pops back. Oh, and this is going back to the beginning. So here I'm going to see if I can speed this up. I want to show that again. So when you release the pec minor, okay, so watch it pop back when I release this. So I release that last little bit, the muscle, and watch this muscle, like the last little bit, and you'll see it just kind of pops back. And now it's right here. So pectoralis minor right there, your core cord right there. It's pretty impressive how much it actually pops back. And this kind of shows, you can see the, there you go. You can see, so I'm pulling it over. So this is the pectoralis minor that's popped back. I'm trying to pull it back to the core cord all the way over here. And you can see one doesn't want to come back. It's retracted back there. And then this is your brachial plexus underneath it. All right, so how did our young lady do? Well, 2 weeks postoperatively, she already had pain relief. She already was feeling good. You can see the incisions have barely even healed. And she's already saying that she was feeling much better. I kept her in a sling for 2 weeks, haven't let her do anything. Her tenels is already going away. Similar to what happens with the carpal tunnel. Carpal tunnel, you release it, initially they start feeling a little bit better, but they still have some numbness and tingling. And then eventually you see them back again at 6 weeks, and now all of a sudden the tingling's gone away. Maybe they have a little bit of numbness, and you see them back at 3 months, and everything's back, and they're feeling great. Similar type of recovery to this. Pain starts going away, then some of the symptoms start going away, and then all of a sudden their shoulder moves normal again. So this is her 2 weeks postoperatively. This is her 8 weeks postoperatively. So usually I'd see her back at 6 weeks. This is 8 weeks postoperatively. Shoulder subjective value, 25% preoperatively, 85% postoperatively, 8 weeks after surgery. Have not done any strengthening yet. Have just basically let her move at home. I did ask her to, she has been doing the same type of therapy, the scapular type of therapy that I've been asking. And even crazier, and this doesn't always happen this quick, but her scapula moves normally. Look at that external rotation, internal rotation. She has a nice smooth external rotation and internal rotation. So there's the medial border, it externally rotates and internally rotates. There's no more scapular winging. And then 14 weeks postoperative, and I don't have, I didn't put the video into this talk, I should have. I literally just saw her last week. But 99% shoulder subjective value. She's returning to softball at 14 weeks. Initially, long story. My partner is Jewish, and I'm Christian, and our teams for Christmas bought us, we told them we'd wear whatever they bought us, and they bought us matching suits to wear to clinic. So that's where that comes from. But nonetheless, all right, so once again, so you can see her scapular dyskinesia looks great. She's returning back to softball. She's back in softball. She's playing softball right now. She has no symptoms right now. She's doing basically everything's kind of gone away. Her patient board outcome measures are all basically back to normal, and that was at 14 weeks. All right, so summary: plexus is a complex. It takes years for surgeons to learn how to do it and to kind of try to figure it out, and we're still learning how to do it and figuring it out. Neurogenic thoracic outlet, I do think it's something that we're seeing more and more. I do think it's something that patients that have this kind of vague shoulder pain that's maybe failed a prior surgery or something like that, this kind of anterior shoulder pain, this radiant shoulder pain that they thought was neck, but they don't have neck pain. And I'm seeing it a lot. This young woman's a good example, but I'm seeing it a lot in these overhead athletes. Most of them, if I can be frank, are women. I don't know why that is. But volleyball players, swimmers, and softball players tend to be the ones I've seen it relatively frequent in. I guess two tennis players that I've seen as well. But nonetheless, I've seen young patients. I have also seen some older patients. I do think it's out there a lot more than we recognize. I do think people have it, and usually they're just told there's nothing I can do, or I don't know what it is, or your shoulder pain's not from your rotator cuff. Or your biceps, so there's nothing I can do for you. So I do think it's actually out there more than you realize. I think if you listen to your patients, you observe your patients, you look at the scapula, you look at you put your hands on them. I do think it's out there a lot more than you realize. Not to say that everybody needs surgery for it, but I do think it's out there a lot more than you realize. I do think you can make a big difference by just correcting their posture, and then when they're doing different exercises, getting their posture, getting their scapula, really kind of focus on their scapula. I do think suprapubic neuropathy is real. I do think it's almost like the same as carpal tunnel and cubital tunnel. And I do think as more and more surgeons learn how to do suprascapular nerve releases, I do think we'll hear it talked about a lot more. The take-home point, if I can tell you anything, is listen to your patients, put your hands on them, focus on the scapula. Diagnostic injections are the key in my mind to diagnosing most shoulder pathologies. So thank you guys for your time.
Any questions for Dr. Wagner?
Yes.
So if it's specific thoracic outlet with the suprascapular nerve and you've got the diagnosis,
Yes.
do you see a role for us?
Yes, absolutely, 100%. I will never operate on somebody unless they have done extensive, what I consider not just moving the rotator cuff, but extensive therapy focusing on their scapula, focusing on their posture. Well, so carpal tunnel, we know night splints can treat in the carpal tunnel 80 to 90%, 70 to 80% people who get carpal tunnel, especially catch it early, 89% get better with night splints. Night splints, plus or minus therapy. We do know from Washington University in St. Louis, which I can never get patients to actually wear splints, night splints and cubital tunnel, but if you can actually get a patient to wear a splint and cubital tunnel, we also know, according to the Washer group, that 84% will get better, completely cured, never have surgery 5 years later, with splints. Now, these are miserable to sleep in, and I have yet to meet a patient who actually will tolerate that. Nonetheless, we do know that. And I think with this, we do know that it is a scapular problem. I guess we don't know. I think it's a scapular problem. So I think if you can correct the scapular problem, then you can treat the problem.
So this
But
softball player had therapy, right?
she did, but she was literally diagnosed with a slap tear and was being worked up for a slap tear. And then we started focusing on scapula. And she was noticing some differences, but it wasn't a lot. And so in my mind, you have to have 3 to 6 months of focusing on your scapular posture before I even talk to you about your options for surgery. And if you come to me and you said you did therapy and they send you to me because it's a diagnosis of a rotator cuff tear or a partial thickness rotator cuff tear, that therapy doesn't count. I'm sorry, it doesn't count. Doing this, that doesn't count. You have to have somebody who's actually paid attention to when they're doing exercises, bringing their shoulder blades back, doing exercises to strengthen them, doing eccentric exercises, focusing on having the patients focus on their scapula as they're bringing their arms down, using maybe even tail saws or something to bring their shoulder blades back. You have to have that. Or I will, absolutely not. And if I can be honest, there are really important structures right underneath that pectoralis minor. I think it's safer to do it arthroscopically. It's through a couple small incisions, and it's safer, and I think it's a good option for patients. That being said, you still have some very important structures right there. So this is not a biceps tenodesis that maybe it's going to rupture and they're going to Popeye sign. These are, if something went wrong, it's a big deal. There's a big, very important nerves right there. So in my mind, this is not a surgery that I'm all right, you have this, let's sign you up, let's go to surgery. This is something all right, you have this, perfect, we made this diagnosis, all right, here's what you have to do. You have to do this, you have to do this, you have to do this. If I'm going to operate on you, you need to correct your posture. I will not operate on somebody that shows up to me like this. And if they've been doing therapy and they're still like this, I'm not operating on you. You've proven to me that you are not willing to actually participate in a postoperative rehab that will make your shoulder better. So if you can't even just correct your simple posture, I'm sorry, there's nothing I can do for you. So 100%, I actually would argue that more so than almost any other shoulder pathology, you probably have a role in this. Now, that young lady, and certain ones I think present really late, and just like late carpal tunnel or late anything, it's hard to do it at that point. But if you catch it early on, scapular dyskinesia, some kind of radiating shoulder pain, some radiating pain down here, if you catch that early, 100% you can treat it without surgery, and you definitely can treat it. Just like my guy with the sternoclavicular joint. I gave an example. I mean, that guy had been sent to, he'd seen 5 surgeons around the Atlanta area. Nobody wanted to do sternoclavicular joint surgery. Nobody seems to want to do sternoclavicular joint surgery in the South, especially in Atlanta. And so he'd been sent to me, basically been told he needs surgery, but I don't want to do it. He needs surgery, I don't want to do it. He needs surgery, I don't want to do it. He still has yet, I met him a year ago, he still has yet to sign up for it. Why? He corrected his posture. Now he doesn't know if he even needs it. I mean, you know, I literally saw him the other day. I don't know if we'll end up doing surgery on him. So yeah, I think there's a huge role for it, for sure.
All right, thank you.
Yeah.
Very appreciate it. Very enlightening. I've never even considered the citrus potatoes, or never occurred to me
Yeah.
that it was even there. I mean, we all learn this stuff, but then I don't really apply it. But I have seen a couple of thoracic outlet
Yeah.
problems in my life, a few.
Yeah.
Really.
Yeah.
One in particular was a police officer. She was in her drills and practicing flipping, and a person larger than her flipped her over her clavicle. And she went to traditional physical therapy with the overhead.
Yeah.
Anything overhead was just causing
Yeah.
complete
Numbness and tingling. Yeah.
So they referred her to me, I'm a hand therapist, and I listened to her, and I started treating her like she had TOS. Like I wasn't even going to tell her that because I didn't want to give her something new to think about. But it turned out in the long run, it's exactly what she had.
Yeah.
And we finally got her to somebody through her case manager that believed her and did some. I'm not even sure because I didn't even saw her.
Yeah.
She got better.
Yeah.
And this went on almost a year.
Yeah.
But secondly, one of the things I do see a lot
That's awesome.
is impingement syndrome. And
Yeah.
I'm starting to wonder whether this little nerve, because when I evaluate people, they got movement, but it's weak in abduction, external rotation, and they have very weak scapula going on.
Yeah.
And so that's what I looked at. I said, it's impingement, we're working on your scapula. And they go, but it doesn't hurt my back, it hurts. I'm like, we're working on your scapula. And then I use tape, sometimes kinesio tape, that biofeedback, field posture.
Yeah.
But this was enlightening.
No, thank you for saying that. So impingement syndrome. Okay, so I'm not mocking these diagnoses when I say impingement syndrome or slap tears, but there's I don't know if you've read it, but there is a has everybody heard of the Houston VA study? Houston VA study was this very famous study done back, I think it was now 2005, so it must have been like 15 years ago. Houston VA study is where they, at the Houston VA, did surgery where they made incisions and did nothing versus making incisions and debriding out a degenerative knee. So a patient who had some arthritis, mild, moderate, severe, no obvious pathology, maybe some catching or locking or whatever, and they so legitimately performed a placebo surgery, which is, in America, is like no idea how they get this approved. The only thing is, I think with the VA, like, unfortunately, that's the only way this could possibly be done. Yeah. But in Europe and stuff like that, they actually be able to they can do some of these. In America, I mean, you ask a patient to sign up for this surgery, and they will like walk out of your office before you can even like explain the thing to you. I mean, there's no way they'd go for that, and it makes no IRB would go for that. But nonetheless, it did, and it showed no difference. And actually, if you really parse it down, the people in the placebo group did better than the surgical group. It's very, very famous. Very, very talked about some amongst our things, like we talk about a lot, and yet still, if you look at the ICD-9 codes around the country, one of the most common ones performed is a degenerative knee scope. So I mean, it's still something that's done a lot, but it's not. So it's a really controversial topic, really hot topic. A lot of people talk about it, a lot of people debate it. Recently, in 2018, the NHS, National Health System in London, came out with a study where they randomized patients to either, for impingement syndrome, they randomized them to either subacromial decompression and acromioplasty versus making incisions and doing nothing else. Exactly like the Houston VA study. And their results were exactly the same as the Houston VA study. They did not do biceps tenodesis. They did not do rotator cuff repairs. This is just subacromial. This is impingement syndrome. This is subacromial decompression and acromioplasty versus placebo. 2018, New England Journal of Medicine has made a lot of sort of waves, a lot of controversy, talked about a lot since it's been published. We knew about it in 2016. It was presented at the AOS, so we knew that this had happened. It just took a little while for it to actually be in print. So people had heard about it for a little while now. But nonetheless, pretty eye-opening. And I think a lot of us kind of believe that. A lot of us didn't. Still, a lot of us don't believe it. There's some problems with that. I do think that there's certain patients that potentially do have real impingement syndrome. Those who have, my diagnosis of impingement syndrome, bursal side rotator cuff, they have to have all four of these. Bursal side rotator cuff, a type 2 acromion, shaping down acromion, a positive response to an injection, and positive impingement findings. But they have to have all of those. They have to have the positive response to injection. They have to have the type 2. They have to have the bursal sided, not articular side, bursal side rotator cuff tear. And there is a study that showed if they have those 4 symptoms versus anybody who has 3 or less, that the 4 symptoms, they actually do get better, 3 or less don't do as well. So I do think that there is a diagnosis for that. I do think it's not. We're doing an epidemiology study in light of this New England Journal of Medicine study. We found that it is still the second or third highest CPT code that is put forth alone still. So there's a lot of people around this country still doing acromioplasties and subacromial decompressions alone, not with any other CPT code. So is what it is. But anyway, so going back, I was on a tangent. Going back to the supraspinatus nerve, I actually think that bursal side rotator cuff tears and this impingement, I actually think it's probably supraspinatus neuropathy that we're treating. I also think, though, when you're doing a supraspinatus nerve release, I don't know if you guys got the sense, I do think you're actually denervating some of the nerve, some of the thing, because what I'm doing is I'm going back and forth along the acromion and along the supraspinatus fossa. And if you look at the anatomy, there's these sensory nerves that are going along that to the upper half of the glenohumeral joint. So I think when I'm doing that, I'm not only just releasing the nerve, I actually think I'm doing a little bit of a joint denervation. And so I think, for me, a lot of these patients with these bursal side rotator cuff tears, and I've had multiple ones that have sent to me from my partners who have failed biceps plus subacromial decompression, whatever it is, and I go to the supraspinatus nox injection, get some pain relief, and I do the surgery, and it's like it's cured. So I think you're right. I think the supraspinatus nerve is on that spectrum. I don't know. Yeah, I think it's on that spectrum. I think we're going to learn more about it. It's something that we haven't classically learned how to treat surgically. I'm the only one who does it. I think I might be the only one who knows how to do it. I don't know that for a fact, but I think so. And it's not that it's technically complex, it's just people didn't learn it in their fellowship, they didn't learn it in the training, they didn't talk about it. So it's more and more people are talking about it. I bet the people coming out that are coming out now and going to be coming out over the next 5-10 years, I bet there's going to be a lot more conversations about it, because a lot more places are doing this and talking about it. So, yeah.
You mentioned the SSV screen. What does that say?
Oh yeah, sorry, SSV, shoulder subjective value. My favorite question in the world. Every time my resident shoulder subjective value. You will also hear it talked about as the subjective assessment numeric evaluation, SANE. So the SANE score is what it's technically called. In the shoulder world, we call it the shoulder subjective value, SSV. I, along with one of my colleagues and at Stanford, Amy Ladd, are trying to apply it to the thumb subjective value, the wrist subjective value, the finger subjective value, the hand subjective value. So we're trying to validate it in a lot of these different patients. I love it though. I love it because I put it in all my notes and I can literally look from note to note and see objectively, is the patient feel like they're getting better, are they not? We would collect all these patient-reported outcome measures on these patients. That's a 0 to 100. 0 to 100, how do you rate your shoulder? They say, I don't know, what do you mean? Your normal shoulder is 100. A shoulder that is extremely painful and you can't move is 0. Where does your shoulder fall in this spectrum? To give you a sense, like if the average shoulder subjective value prior to a shoulder replacement is about 30%. The average shoulder subjective value prior to a rotator cuff repair is about 40%. The average shoulder subjective value prior to a biceps tenodesis is about 55%. To give you a sense of the scale of what people kind of think about their shoulder in these respects, the average shoulder subjective value, obviously, in the setting of like a recurrent dislocator is like 10%. I think it's like 15%. But it's somebody that's like had failed prior instability procedures. So it's a spectrum, but I love it because I feel like it really helps you to understand what the patient thinks of their shoulder and how is their shoulder actually getting better or not getting better, or how's it getting worse. And if I can be frank, if a patient who shows up to my office with shoulder arthritis, but they tell me that their shoulder subjective value is 70%, I say, great, nice to meet you. I cannot make you better. Work on strengthening your shoulder. We can potentially inject your shoulder if it's really painful, but I probably wouldn't even want you to inject it because it's not going to make you better. You're 70%. The average shoulder subjective after shoulder replacement is like 75 or 80%. Not going to make you better. And so my resident's favorite question is, how do you know when a patient is bad enough to do a shoulder replacement on? I tell them when their shoulder subjective value is at least below 50, ideally below 40. Because that's their view of their shoulder, and that's their view of how bad they are. And I do know after shoulder replacements, my average shoulder subjective value is 82%. And so I do know I can make that patient more than double better. In average. Now, not all patients get in the 80s, but average, I can get better. So odds are I can make that patient better. But if he's 70 or 60, the odds are that little increase, I'm not sure if they're going to be so satisfied with.
Did you find that the predominance of people that you've done the superscapula and nerve release on are what their age group is? I know you said.
Yeah, it's like the way I've seen it so far.
Posture, thinking about how pec minor gets tightened down, or how various things would occur.
Yes.
To create, dysfunction in the dynamic.
Yeah.
And when a humeral joint and the scapula, it makes you wonder.
So there are 3 demographics that I have seen right now that are the most common that I've seen that have ultimately turn out to have it. It is a young female. When I say young, like 20, like teenager, 20s, even 30s, young female who is very active, is doing either overhead sports, rock climbing, something involving their shoulder, and has scapular dyskinesia on their exam.
Which makes you feel like somebody's trying to use their humerus when they don't have stability in their scapula. And so
Absolutely.
then they create those dynamics.
Absolutely. Absolutely.
Okay, so then the next
Absolutely. The next group is what Peter Millett in Vail, Colorado wrote on and described and see more and more on, is the young male who really who either has very poor posture or does a lot of chest workouts, bodybuilding, and is sitting like this, or one side is sitting like this, or both sides are sitting like this. Peter Millett is this shoulder surgeon in Vail, Colorado at the Seven Hawkins Clinic. He called it pectoralis minor tightness. And he described, most of them were young men, and yeah, exactly. And they're like this. He described going in and releasing the pec minor just purely when they failed 6 months of trying to retrain them, release the pec minor, and he described a series of patients that did very well with this. I do see that. I don't see that as often as the other one, but I have seen that. I do see that, and I've had a couple that have had nice success from this pec minor radialis minor. It's really, they do have pain, but it's really like it's pain. It's not as much radiating down their arm. It's pain. It's some weaknesses, some dysfunction. It's one side doesn't function as well as the other, and sometimes one time really drastically. Like legitimately could not move their shoulder and their scapula wasn't moving at all, and I thought it was serratus anterior palsy, and it wasn't. The serratus anterior was working on EMG, and it wasn't serratus anterior, and like released it 2 weeks later, like that, he was much better. That I was not sure about going in, if I can be frank, and definitely like there's so the pectoralis minor, I'm still working out tightness. I'm still working on my head, but that's Peter Millett has a nice article he just published on arthroscopy, I think in 2019, on that. And then the last one is the people that are have been sent to me that have failed other procedures and have, in most of the time, it's like kind of middle age. Most of the time it's like a radiculopathy type of thing. People think that they had radiculopathy problems. They've probably had either spine or like a biceps tenodesis, subacromial decompression type of stuff, and nothing's really gotten better. And so then we go and inject it, and those get better. I'm still working out that group. I think that's once again along the neurogenic thoracic outlet syndrome. Most of the time, those patients have some abnormalities in their scapula. That's the group that I think is more common than we realize. I think we just haven't exactly learned. I think that's the group that's more common than we realize. And that's the group I'm learning more about. I've definitely had some people I thought had it. We did some injections, and I've become much less confident that I've had it. I've had of all the pectoralis minor releases that I've done, the only one that I can think that definitely did not get better at all after that whole workup and proving was somebody who had fit that category. If I can be frank, didn't really get better from the injections, but had a very classic like pain here. I was convinced that they were going to get better, and they didn't get better. That's why I'm even more of a stronger believer in these injections. I do think, I'm not sure if I'll ever do that again. Do it if somebody doesn't get a response to the injections, if I'll ever actually release it again.
How long do those injections last?
Well, for me, it's a diagnostic thing. It's not a treatment thing.
If you can get somebody that to be a little bit more pain-free, then they might be able to participate in therapy.
For sure. And that's why I do steroids in all of them, because the idea is hopefully they'll be able to get some pain relief. If I can be frank though, and that's actually a good point, I actually, before we do the injections and all that stuff, if I think they have it, I make them do therapy before we actually go down that route. And maybe you're right. Maybe I should be doing.
Like flared up or
Yeah.
something, right? And then they're sort of turned off.
Yeah, you're right. Yeah, I think you're right. I mean, I think you're right. I think it would. The only problem is when you start doing injections on these people, they, in their mind, kind of think that you're like moving down the surgical path. That's why I, at least up to this point, have been making them do some like real scapular therapy before we go down that path. But you're probably right. I might need to rethink that. The challenge with these patients, that last group that I said, is a lot of these patients are not so happy. A lot of them had failed prior surgeries. A lot of them are being sent to you by surgeons in part because they can't figure it out, in part because the surgeons are sick of dealing with them. Yeah. So it's, and I've definitely been sent plenty of people for thoracic outlet who don't have it, but have vague pain that I have no idea where it's coming from. And the surgeon is saying, oh yeah, I think you have thoracic outlet because they wanted to get them out of your clinic, and now it's your problem. But yes, first becomes your problem. Yes, absolutely. Absolutely. Yeah, exactly. So those are, I don't know, it's such a challenge. That's such a challenging patient. The young patients don't really want surgery, and so the young patients, absolutely. And I actually, the young woman I showed and multiple other ones, we've, not the pectoralis minor ones, because I mean the pectoralis minor tardinus, I'm not sure if, I guess the ones that are really painful it is. The ones that are really dyskinetic, I'm not sure. Maybe injection would work. But I think that the young women, they often don't really want surgery. And so I think a lot of them, like McKerney, between when we first injected her for surgery, I think it was 6 months. Sorry, I shouldn't say her name, but like you said, she gave me permission to do this. But the young lady that I put here, she, 6 months. So she really didn't want to have surgery. I tell these patients that this is not a risk-free surgery, that there's some very important structures underneath there, and while I haven't seen complications in this arthroscopic procedure, that I have seen some very major complications in the open procedure. I often will tell them that death is not something that I would anticipate or ever expect, but in orthopedic surgery, that's very rare that most procedures we do can actually cause death, but theoretically, this is a procedure that you could cause death in. And so it's not like I talk them into these surgeries. I definitely try to talk them out of doing these surgeries because I'd rather them get better. I'd rather them get better. I'm just gonna put that right there before I break my computer. I'd rather them get better without having to do that. Like generally, I would rather them get better than having to do that procedure. So,
I have
yeah.
a technique that works really good. I think when their shoulders are hurting so long, they're guarding so long that their trap is so tight. They pulls their shoulder blade up and over, and I think it keeps that nerve and makes this tight too.
I would agree.
So if I put my E-stem with I use an H-wave because it's got a nice deep thumb with a hot pack, that muscle has so much lactic acid they can't relax it anymore. They don't even know they're doing that anymore, you know? And I put my hot pack with my H-wave to open their blood vessels, wash that whole blood out of the lactic acid so they can relax. And then they can go, oh my God, I didn't even know I was doing
You
that.
can't upper rotate your scapula when it's elevated. That's depressed, and then upper rotate.
Well, and then when they do their back and down, their depression retractions, they can feel their trap stretch, and they go, wow, because they can't do it before because that's just so tight. It's like trying to drive a car with the brakes on, you know? So I do that hot pack and the E-stem and get that relaxed, and then they can work on their posture. So that's a way to kind of like go back to, you know, they don't have an injection, to kind of, I have great success with that.
How much carryover? Can we hear past your session?
Well, if I keep doing their back and downs, because to do that, that has to be inhibited. So, and chin tuck too, that way they open up all the cervical places that their nerve could be inflamed too. So I just back and down and chin tuck, and this gets stretched, that gets strengthened, fixes the postural balance. But yeah, they come back and sleep with, they want to sleep like this and stuff, and they'll hack it up again. I try to have them sleep.
Thank you for doing this.
No. I was going to show you something. We had this really cool. There, it's real quick. I'm going to show you guys this. We had this really cool technology that we have. That somehow our chairman convinced this company to trial called Konica Minolta DDR. It's this low dose. It's like kind of like the scoliosis, the low dose scoliosis X-rays. We figured out this way to do this low dose radiation, where basically in the amount of radiation it takes to take 1.5 normal X-rays, you can do this dynamic X-ray. It's done a lot for. We are finding ways to analyze it, but it's done a lot for me understanding how much the scapula contributes. But you can see how much the scapula contributes to motion, like how much the scapula is actually moving compared to how much the glenohumeral joint's actually moving. Sorry, it's incredible to me. I think one of these. I'm not sure if one of these. I have one of these that has a rotator cuff arthropathy. There you go. Watch his head shift up. So do you see? Watch the head move, and then watch the scapula. Oops. So watch when they move. Watch his head shift up. So it starts down. There you go. You kind of see the shift. The head shifts up, and they're actually moving their scapula. You record, oh, they have 120 degrees of elevation, but really most of it's coming from their actual scapula that's causing this. I think, I might be wrong, but this might be the frozen shoulder patient that has this. No, that's not it. Anyways, I have a frozen shoulder patient that has it where they're like this. They're like this. They kind of get like this. And nobody diagnosed with a frozen shoulder. And like you looked at this, and like before I even went and met the patient, you looked at it, and their shoulder wasn't moving at all. It was all their scapula. It got up to 90 degrees. Yeah.
All your muscles are tight.
Yes, but your point with this shrug, I do a lot of these. I do these arthroscopic assisted lower trapezius transfers for these massive irreparable rotator cuff tears, and in general they do pretty well. One of the patients I've struggled the most with is the patients who had prior rotator cuff repairs that failed, have compensated by doing this a lot, and try to lift their arm, their shoulder by doing this a lot, and then when you do a surgery on them to get it back and rebalance, they still want to do this though. And you still have to train them not to do this, because like this, nobody, if you do this, lift your shoulder. Nobody can lift their shoulder like this. And so it's like a muscular retraining of how to move your shoulder. it's so difficult and yet so prevalent, especially people who've had shoulder pain for a while. But no, there's this trapezius inhibition almost. I don't know. Yeah. Anyways.
Thank you, great.